want to welcome you and thank you for joining us today as we talk about children's mental health services in Michigan. We think this is a very, very important conversation. My name is Marianne Huff, and I am the president and CEO of the Mental Health Association in Michigan, better known as MHAM. MHAM has been around since 1936, and our work is primarily focused on public policy at the state level for individuals, adults, kids, and youth who have mental health conditions and addictions. Tonight, we're going to have a very important, serious conversation around Michigan families who have children with serious emotional disturbance, behavioral health challenges. And a lot of these families are experiencing some pretty significant challenges in getting the specialty services and supports that they need, particularly through the public mental health system. We're going to talk about those problems that families have when they're trying to get in the door, and then also what happens once they do get in the door. We also want to focus a lot on possible solutions too, because we don't want this to simply be about what's not working. There are things that are working and some areas that could really be improved. We know that the pandemic has really revealed a lot of the issues that we have in a lot of systems, and not just mental health, but in physical health as well. You know, we have these systems for a reason, and Michigan, like most of the 50 states in our country, has a publicly funded mental health system that is designed to provide specific types of services to individuals with more severe and significant mental health conditions. Systems are meant to provide specific types of assistance, and there are times that systems that have been around for a long time can and do have a difficult time doing what they are intended to do. And as I said earlier, in all fairness, the pandemic has certainly demonstrated cracks and crevices of many systems. However, regardless of the reasons why systems fail to keep their promises, the impact of those failures lands squarely on the shoulders of the people and the families who need access to what the service is supposed to be providing and offering. So tonight we're going to take a look at the problems that families are struggling with and some of the solutions that are also available. However, before we get started, and this is only going to be a few moments because I know we have a lot of participants on this call, I just want to kind of share some data with the audience. I want to share with you, since we are talking about children's mental health, is data that's actually taken from online mental health screenings that Michiganders have availed themselves of through either our website or through the Mental Health America website. Mental Health America is our parent organization at the national level, and we began hosting these mental health screenings on our website last year, and the data is compelling. So for example, we got data from between January 1st, 2019 and December 31st, 2021, over 80,000 Michigan residents took part in the mental health screenings. You can see the data here. Basically, what was disturbing was that depression was the #1 mental health condition that individuals who took the screenings experienced, with over 30% having indicators for depression, either, testing positive for the condition. Second was anxiety disorder, with 19% of respondents testing positive or in the more moderate to severe range. What is really disturbing, and then the third condition was bipolar disorder. But what was most disturbing was in this round, 33% of those who participated were between the ages of 11 and 17. 31% were between the ages of 18 and 24. And then according to the 2022 Mental Health America Annual State of Mental Health in America report, Michigan ranks 27th in the nation when compared to the other states with regard to mental health. This means that we have less access to care than 26 other states in our country, and we have a higher incidence of mental health conditions among our children and youth than 26 other states. And this is something that we should all be concerned about. So this is just a picture of some of the data. Just real quickly, we're not going to put it up on the screen, but when we got our quarterly data for April through the end of June recently, what was interesting was that individuals between the ages of 18 and 24 took these mental health screenings, and then the group between the ages of 11 to 16, 17, they took the screenings. It was kind of reversed this time. So I just wanted to share that with everybody. Also want to say before we get started with our panelists and I introduce everybody, that you're welcome to drop comments or questions in the chat box. It's going to be monitored by Kristen Taylor, our staff person here. We're going to be moderating them. And then towards the end, we'd like audience participation and interaction. So without further ado, I'm going to go ahead and introduce our panelists, our roundtable guests. So the first person I'd like to introduce is Mrs. Laura Marshall. She's co-founder of a group called Advocates for Mental Health of My Youth, Michigan Youth, and she is a parent with lived experience. Laura is a wife of 22 years and a mother of 3 boys in Cedar Springs, Michigan. She has spent the past 11 years learning how to navigate the mental health care environment and has a passion for advocacy for all those in need of mental health services. She is also currently navigating the world of being a football mom and is also a board member of the Mental Health Association in Michigan. Welcome, Laura.
Thank you.
Also with us is Miss Jan Lampman. Miss Lampman has worked with individuals with intellectual and developmental disabilities since 1985. 27 of her years was with the Arc of Midland, developing new initiatives and helping to create a culture in her community that supports values, includes people with intellectual and developmental disabilities. Jan was a founding member and faculty for the Michigan Academy for Self-Determination, as well as a consultant for the Center for Self-Determination. Jan is currently the owner of Community Drive, a consulting and training organization dedicated to promoting self-determination, person-centered planning, community positive change, and thriving. She's the mother of 2 young men, 1 adopted out of the foster care system. It's great to see you, Jan, and really thank you for joining us today. Also joining us is Mrs. Michelle Massey Barnes, co-founder of Advocates for Mental Health of My Youth, Michigan Youth, passionate advocate and parent with lived experience. Michelle became a co-founder of Advocates for Mental Health of My Youth after facing incredible difficulties navigating children's mental health. Michelle and her husband have 3 children, and finding proper supports for different needs often feels like an impossible feat. Michelle's family enjoys watching Marvel Studios together. Michelle promised MHAM that she will not hulk out at tonight's roundtable discussion, even though she admits that being a mental health advocate frequently requires the strength of a superhero. Thank you. Before I introduce Kyle, I do want to say that the way that this group started was actually through David Lloyd of the Kennedy Forum in Washington, D.C. Michelle reached out to David Lloyd asking for some help navigating public mental health in Michigan. David Lloyd emailed me, and what started with Michelle and then Rachel and Laura has now blossomed into a group, a private Facebook group that now has over 300 families who are in the same situation. So I just wanted to offer that up, and MHAM is really, really proud to be able to support this grassroots advocacy effort on the part of these parents who are just trying to get what their kids need. So I would really like to also take the time to, I want to introduce Kyle Williams. Kyle is the Director of Litigation at Disability Rights Michigan, which is the former Michigan Protection and Advocacy Service. Kyle has been the litigation director for 3 years. Prior to that, he was an assistant attorney at city attorney at the city of Jackson. He also was a staff attorney at Michigan Protection and Advocacy prior to its name change of Disability Rights Michigan for 3 years. His work is totally focused on preserving the civil rights for individuals with disabilities. And we're real grateful to Kyle because he has been an absolute wonderful resource We're really glad to have you back, Kyle, as a subject matter expert. And we thank everybody for joining us today. And we look forward to your perspective and your guided wisdom today. So without further ado, what I'd like to do is I'm going to start with Laura and then Michelle, just kind of give a brief overview of their stories. The reason for doing that is because each individual here, each of our 4 panelists has a different perspective or point of view about what is not working with regards to children and youth mental health services in our state. And so I'm going to ask each of you about your experiences with the system and your opinion, what are the problems that need to be addressed? And then we're going to move on to solutions. So Laura, why don't you start with giving an overview of some of the issues that you've experienced?
I find myself in this position today after years. I think Marianne had said, I've been trying to navigate the mental health care system to find supports for one son in particular for about 11 years now. And this son happens to be adopted. Not going to say that my other 2 children don't have some mental health concerns as well. As a matter of fact, my oldest does have a diagnosis as well. But what we deal with on the daily is it happens to be the child that was adopted. And if you were ever to hear his story, that is not mine to share, there would be no doubt in your mind why he faces the tremendous challenges that he does with mental health. We'll say in the first 14 months of his life, he went through nearly insurmountable losses, just loss after loss. And so having prepared myself for adoption and, reading the books and, feeling like I was somewhat knowledgeable on what pitfalls there could be, but we'll just love them enough and we'll get through it. That was sort of the philosophy. And it's unfortunately a bit of what the adoption agency also kind of would direct you to think. So about 1.5 years, maybe after my son was home with us, again, he came home with us at 14 months. I remember contacting the adoption agency and asking for help because it just felt like we were drowning. Like my son didn't sleep from the day we met him, just was not able to sleep through the night, did not nap well, and just kind of went through one rage to the next throughout the day. And it was just so exhausting. And so I reached out to the adoption agency and asked what resources they had. And they did provide a list for me. And I remember there being about 7 or 8 things and thinking, wow, this is great. There's a lot of support. Except for at the very end of giving me that list, they sort of threw in the caveat of, so if any of these things actually work, could you call us back and let us know? That was a pretty big red flag and should have been sort of the warning for me, I think, moving forward. So yeah, fast forward to, we'll say 3-year-old preschool. 3-year-old preschool was 2 days a week for 2.5 hours a day. And he was actually expelled for aggression. He didn't even make it 2 weeks. So that would have been 4 school days. Didn't even make it for 2 weeks. And, the aggressive behavior was already being seen. So we had to pursue psychiatry and medication at a really young age. I've always been one that if I don't have to take a med, I'm not going to. I've really had to put that whole concept in, push it to the back of my head, because that's just not the life and the way things move when you have a child or youth with mental health challenges. You sort of get plunged into the world of medications and med trials to the point where it's so unfair to your child. You watch in fear as they try the next one and the next one, and work with various doctors that sometimes you feel like they listen and sometimes you feel very clearly that they don't. So navigating that was really difficult. So again, early on, we figured out that we needed much more help than I could through what I call the normal parent. What's normal, I don't know. We all say kids don't come with a handbook, but when they have this tremendous level of mental health challenges, you can't do whatever traditional parenting or whatever you feel like comes first nature. You need to be this therapeutic, intuitive, creative, and really well-intentioned parent to be able to address the challenges that literally come daily. And so we started with attachment counseling very young. We did attachment every single week for 4 years straight, still saw challenges. And I had discovered some information through a group called AFSN, Adoptive Family Support Network. They were offering some free classes at the time. And I went and I took some classes about TBRI, which is trust-based relational intervention. Incredibly well researched, thought out. It comes out of Texas Christian University, so it is very strongly faith-based, but just had some really tremendous tools for that therapeutic parenting that just doesn't come naturally. It's not what you would just wake up one morning and think, hey, I'll try this. So despite that intense level of training, we just continued to struggle with challenges. So fast forwarding to third grade. In third grade, we were at that time working with an independent therapist, and he had diagnosed my son with bipolar disorder. And I have come to learn the hard way that there's a lot of dispute over that. So we ended up in Helen DeVos Children's Hospital at one point, and my son had been there a number of days and ended up in a position where the on-staff psychiatrist did not believe in, that's literally the term she used, she didn't believe in pediatric bipolar. So she sent my son home without meds to stabilize. And my other two children then needed to be moved out of the home for about a month while we got him back up on medication and stabilized. And so our journey just kind of continues. We've had the SED waiver shortly following that experience. So starting in about third grade, we had the SED waiver for a number of years. The reason that we pursued the SED waiver, because we didn't really know what we were doing, was because there was talk about respite. And just with the ongoing daily challenges, we thought this will be the key. If we can get the respite that they're talking about through this waiver, like we could plan, say, a long weekend every other weekend, like maybe a Thursday evening through and he comes home Sunday, and we'll be able to really take a break and recharge knowing that our son is safe with trained professionals. Well, he went one time, and that first time we got a call to pick him up early due to aggression. So we were devastated, but we said, okay, then we'll utilize the crisis respite services. There's much less hours per month available for that, but we'll utilize that. And I was very quickly told, no, you're not eligible for that. He's not severe enough. And so this is a really great picture of where we found ourselves from that point to today, even that we just fall through these cracks of we're too severe here, but we're not quite severe enough in all these other areas. So we do the SED waiver back in place for my son once again. And despite that, we are now facing a situation where my son is taller than me, and he's strong, and I can't maintain safety in my own home. Like that is my goal on a daily basis, is just that basic, simple level of safety. And I am unable to maintain that level of safety in my home, despite having the SED waiver. The SED waiver is then to provide a wraparound service, which is a coordinator who can help with communication and planning. We have a therapist that is supposed to come to the home or the school, but meets with him in person. CLS is Community Living Services. They work with my son to model safer behaviors and help him to process when he does have these frequent episodes of raging. We have utilized music therapy. That wasn't effective for him. There is recreation therapy available. Again, that wasn't able to be put in place. We recently requested therapeutic foster care. It is written in the SCD waiver as one of the potential provisions, but we were told that essentially it's really not available in the state of Michigan. There are no families. There are so few. I think it's less than 8 families in the entire state of Michigan. So that is not an option. So where my son now lands due to his aggression is he is now on his 4th stay in juvenile detention. I have had the CMH in my area very specifically to my face tell me that the only way moving forward is to go through juvenile justice. So to criminalize my son because they can't provide the services that are mandated through the SCD waiver so that my son can actually be thriving in the home and community. The whole point of the SCD waiver is he qualifies for the waiver due to severe behaviors and mental health concerns, actually is at a level where he does qualify for inpatient hospitalization at a facility like Hawthorne, which is the state mental health hospital. We have repeatedly been denied the request for placement at Hawthorne. He has never once been in a therapeutic placement, despite having mental health services and supports in theory, but he is now on his 4th stint in juvenile detention. And this one is, he's at 8 weeks now and with not really a great outlook for the future. The unfortunate piece beyond that is if they decide that he's been there long enough, they send him home when they decide, and the cycle starts all over. There's more aggression in the home, or there's more aggression in the school setting. And then it starts all over. And my family is not safe until he's removed from the home. And my desperate plea has been continuously that he be placed in a therapeutic environment with counseling and therapies to truly work with him on his mental health.
Thank you, Laura, for that, for sharing your story. It takes a lot of courage to do that. And unfortunately, that's one of the issues that families like yourself are experiencing, is because there isn't an appropriate array of services in the community. A lot of folks are finding their kids in juvenile detention when they really need mental health treatment. So thank you for that.
Thank you.
So I'd like to turn it over to Michelle, for Michelle to, tell us a little bit of her story.
Thank you, Marianne, and thank you, Laura, for sharing. Laura did such a good job really talking about some of the real life struggles. I wanted to add just a layer of difficulty that I'm having with the system that I know a lot of other parents are having as well. My family is currently working through a very complex situation that requires a high level of coordination of care. We have a pretty big team. Important that everyone on the team is on the same page and moving in the same direction. I think you can imagine that when you have a lot of providers, if people and providers are taking different approaches and trying to do the same things different ways, it causes a lot of stress and confusion. And this creates just like a whole chain of chaos that is very difficult for our entire family. So this is exactly what the wraparound service was intended to provide: care coordination across services that are in the public mental health system and outside of the public mental health system. Wraparound was designed for the most vulnerable kids in the state of Michigan that really need the highest level of outpatient care. We've worked with Wraparound for the last year, but we haven't been successful in care coordination. As a matter of fact, we haven't even been successful in accessing all of the services that we need to coordinate, let alone coordinating the services that we do have. There have been difficulties with scheduling. There have been difficulties with care not being provided face-to-face. There have been so many difficulties with services not being provided in fidelity to the model. The authorization process hasn't been followed to policy. And instead of having a functional wraparound team working together to get the needed services put in place, we've had core services denied. We've had to appeal denials of core therapeutic services. There are too many layers and too many providers, and all of these people are doing things differently with no cohesive plan that truly captures the need of our family. It's no wonder that our family is struggling. We really feel like we've been left to sort all of this out by ourselves with very little help and without an action plan. It's quite honestly been a train wreck. It's now been 10 days since we even have had a wraparound coordinator or a main point of contact to call. Our family is in crisis, and our emails and our phone calls are going unanswered. Instead of working with our family to solve these problems and to figure out how to get services put in place, there's finger pointing, there's bickering, there's blaming. We can't get everyone on the same page. We can't solve the problems because more people keep stepping in that have not worked with our family. And instead of listening to what the family is saying that we need, and instead of listening to the providers that are working with our family, each new person comes in and asserts that they have the magic answer. The real truth is there aren't enough resources. There aren't enough of the right resources. And to be perfectly honest, there aren't even enough of the wrong resources. Our child simply isn't getting treatment, and our family continues to experience distress from the very system that is designed to provide relief.
Thank you, Michelle, for sharing your story with us. So now I'm gonna go to Jan and then Kyle. You guys are both like experts here, and you've just listened to Laura's story and you've listened to Michelle's story. So I'm wondering, from your point of view, Jan, what are your thoughts and what are some of the things that you've seen in the system? And then, you know, just some feedback about what you just heard.
So I think Michelle summarized what we're seeing across the whole entire state really well, in that there aren't enough resources. But also the resources that we do have, sometimes folks are not as well informed or as well trained, right, in the issues that they need to be trained in as they should be. For example, over the last couple of years, because of the pandemic, I've been asked to facilitate person-centered planning process in parts of the state I normally wouldn't be in, you know, because I can do it on Zoom. So I can, from Midland, facilitate a plan in the UP or over in Grand Rapids or down in Jackson, right? And so what I have found, I can't tell you how many times in the last 2 years I've been starting to engage in process with, whether it be a support coordinator, a case manager, or a wraparound coordinator, and they have never heard of this idea of facilitation of the process. They've never heard of independent facilitation, which is a service you can get that's in the Medicaid provider manual, right? And so these professionals don't know about that. And then when we begin to engage in that process, often those professionals that are responsible for writing the plan and making sure that the services get put into the plan also are not always as well informed about what is available, what is in the Medicaid manual, what is, you know, how to write the plan in a way that is meaningful for the person and the family. And so I see a sort of a training and knowledge issue that's out there in the bigger world. And then there's so much turnover. My own son received services, my youngest son, who was adopted I actually sadly met him in the juvenile care center because he had been there for more than a year because he had come through abuse and neglect and foster care, and there were no parents involved any longer. And nobody had figured out that he even had autism. They just supposed that all of the behavioral issues he was having were just that he was a delinquent, he was just a bad kid, he was just destructive, and all the things, right? And so we are seeing a lot of, that foster care system doesn't always recognize that kids need mental health services, right? The courts that are criminalizing or that are, detaining children don't always recognize that there are mental health needs that are not being met. And so I feel like it's a part, that lack of knowledge. And then when you do get somebody who recognizes you need the services, then there aren't providers to provide the services, right? Therapeutic foster care is a wonderful, wonderful thing that is part of the SED waiver. And you can't find therapeutic foster parents if you ask any of the community mental health organizations, right? They just are not able to find them. In my county, we have a hybrid sort of court foster care practice that mirrors what therapeutic foster care looks like in the SED waiver, and it works beautifully. So we know that if we can get out there and talk to foster parents and give them the support and training they need, maybe we'd be able to recruit some, right? So I see issues of capacity as well. Where are we going to find therapeutic foster parents? Where are we going to find CLS, community living support providers that understand how to support a young person with mental health needs? The third thing that I see, and also professionals, right? All this turnover of these young professionals. How are we going to find enough social workers, enough wraparound coordinators or facilitators? But then the third thing that I sort of see with teenagers is it begins to also get confusing when you've got say a 16 or a 17-year-old, let's say 17-year-old, and then you try to take them to the hospital, and the people in the hospital say, well, they're 17, they can do things without their parents. They don't have to stay here just because their parents say they need to, right? And so then there begins to be that ambiguity about how you support those young adults, right, that are not quite 18 yet, but it seems as though they have some rights to refuse treatment or to not be engaged in treatment that maybe younger children don't have. So those are the three things that I've seen a lot of in Michigan as far as issues, concerns, problems.
Thanks for sharing that perspective, Jan. As someone who's been doing this a long time yourself, it's real helpful to have that point of view. I'm going to now turn it over to Kyle and basically ask you, Kyle, the same question I asked Jan. You've listened to Laura, you've listened to Michelle, they told their stories, you've heard Jan's perspective. What is your point of view on, I'll say, all of this?
Yeah, absolutely. Thanks for having me, Marianne, and thanks, Laura and Michelle, for sharing your stories. I know that this is difficult. This isn't the first time you've had to do that, but it's important that the folks can hear what's going on the ground with these particular issues. And I think, what I hear from those two stories and what I see in the chat, which is a lot of here's and me too's to the stories that you're sharing, is really a two-part issue. One is that people have problems getting services that everybody agrees that they need. If you were to poll the parents and the families that are on this call, a majority of them would likely not be receiving the services that are contained in their IPOS in the amount, scope, and duration that the services are authorized in. And there's a lot of reasons and problems that are contributing to that. But as an initial core issue, people cannot get the things that they need, and not even getting into a dispute of what that is. So whenever you talk about going to your CMH and having respite in your plan and not being able to get it because there's nobody available to get it to you, that is a really core systemic issue that is producing outcomes for children that are negative, that's leading to incarceration, that's leading to ER visits, it's leading to psychiatric hospital, and it's leading to those issues recurring. And so as an initial baseline issue, to be able to just get the things that everybody agrees that you get would be a good first step in trying to make some progress towards addressing some of these issues. And then ultimately, if you're able to get all of the things that you can get your CMH to agree that you need, then you're talking about getting into quality issues with those services and making sure that they're effective at keeping you in your home and keeping you out of jail and keeping it from your parents having to call the police and take you to the ER, that the services are meant to be effective and meant to, treat and ameliorate the mental illnesses and other disabilities that kids have. That's the purpose of the services. And so what I hear in those two stories, and what I think is a common experience for a lot of people, is what's on the menu issue, that you go to your CMH, you become assessed, or you do an intake, they assess you, and then they tell you what you can get. The way the Medicaid program should be working in this state and in any other state that participates in the program should be assessment of what is medically necessary for you and what is a covered service under the program. So whenever, your CMH is telling you that you may need something, but it just simply isn't available, then that's not how the system is supposed to be run. And at the end of the day, if folks are able to access services that are medically necessary, if they're able to get quality services, if they're able to get those services in the amount and the duration that they need those services for, and those services can change to address changing needs of kids whose needs are changing on a day-to-day basis, then you're going to have a system that's going to have a direct impact on kids' ability to stay at home and go to school. I think what I found from talking with a lot of families over the course of the last 3 years is that, parents of kids with disabilities really don't want anything different for their kids than any other kid with or without a disability. We all know that we're going to get older and we're not going to be able to take care of our kids, and we want them to be independent, and we want them to get an education and be able to get a job. And that's really what these services are geared at, is giving kids at least the chance to have those kinds of opportunities, and to try and help the parents that are trying to put their kids in a position to be able to achieve those things. Because nobody wants their kid to be in jail. Nobody wants their kid to sit in the ER and have Risperdal shots until they can't speak. People don't want this. You can work a system that can have an impact on that, and you can judge its success by how you successfully care for kids in the community, and can keep kids out of those kind of settings and keep kids out of psychiatric hospitals. And whenever they go, to get them out and to give them a care plan that can give them a chance to not have to continue to go back in. So I think that's kind of what I hear, and what I hear a lot. And what, to me, are kind of the two primary barriers to having an impact on that issue.
Thank you for that. One of the things I was thinking when you were speaking, Kyle, is we've got a couple issues. One is, seems to me we need a more robust continuum of care, because right now we have either outpatient or inpatient and really nothing in between. Mm-hmm. If families can't access these specialty services that are really only available through community mental health, like community living supports, like respite, like therapeutic foster care, if they're not able to access those services, and we know that we only have one remaining state hospital for children, Hawthorne Center, which has a waiting list. What do families do in the meantime when they're struggling so much? Not only is there a lack of array of services, but then the other issue is the direct care worker crisis, and the fact that we can't get people to provide the services. In your mind, how has this impacted families based on what you've seen? We have people who can't get their children in for acute inpatient treatment when they're in the middle of a crisis. That's number one. Some people are struggling to get their kids even qualified for community mental health. Then they do get them qualified only to find out that there aren't any providers for the services for a variety of reasons. And then, parents who have children with serious emotional disturbance and behavior challenges, that's a tough gig. It's a very tough gig. And I know because it's been 30 years, but I'm the mom of a child who was SED back in the day. And when your child is out of control for much of the time or struggling, it can be really exhausting. So, not only do we have CLS issues, community living support issues, which is designed to keep the kid in the home, but then also respite, which is a service that's so vital, is not available. So my question to you is, how has the lack of availability of mostly these services that are designed to keep children and youth in the home affected families and kids?
struggling with your kid whenever their kid's in crisis. One of the things we could stand to benefit from greatly in the public mental health system in Michigan is utilizing crisis intervention strategies that are community-based and not relying on jails and emergency rooms to deal with mental health crisis. If you go in and talk to a hospital and you go and talk to a jailer, they're going to tell you, I don't know how to deal with these issues, and this is not the place for these kids. One specific Medicaid service that's been clinically proven to be extremely effective at addressing crisis is in the community is mobile crisis service. And so having a team of individuals that's familiar with your child's care, be able to come to that child in the community and address the crisis and ideally stabilize the crisis. A service like that, whenever it's effectively run, can have an immediate impact on, not only the number of police calls that are coming from children, the number of ER visits that the children are having to go to. It can have an immediate impact on the number of kids that need to be psychiatrically hospitalized by specifically, dealing with the crisis and, adjusting your service plan after that crisis has been dealt with in the community. So, that's a real area that has a high potential for improvement in the state. If you can get the necessary infrastructure and get the correct people in there that can run a mobile crisis unit effectively. You talked about trouble getting into the door. Under state law, there should be no cap for services for kids. And in particular to the STD waiver, there should be no cap on the amount of kids that can get into the STD waiver. And so there should not be introductory intake-based restrictions on getting kids that need mental health care and services, regardless of whether or not they're on Medicaid or, have any other kind of different insurances. That it's extremely important to identify kids as young as possible who may have mental health issues and do your best as early as possible to try and intervene and try to ameliorate some of the symptoms from those mental illnesses. Because, these are all things, it's just like cancer. If you don't treat cancer, then it gets worse. And the same can be true in terms of mental illness, especially at a young age. You also talked about accessing resources whenever you get into the door. And we all just need to take a pause and realize that we have a tremendous direct care provider crisis in this state. It has been a problem for a very long time, and it is an absolute crisis right now. And like most things, COVID has not helped it. And there's a lot of contributing factors to why we have crisis. A lot of it surrounds the job. This is an extremely difficult job to provide CLS and to provide respite to this population of kids. This is a job that requires tremendous emotional intelligence and strength. It requires physical strength and a number of examples. This is a job that comes with extremely harsh penalties whenever you make mistakes in it. If you have a wage that is comparable to going and flipping a burger at McDonald's or working a cash register over at your Costco or your Walmart, then people are going to go and take that job. And that's just how a labor market works whenever you have a labor pool competing for workers at the same wage. So there needs to be, an appreciation for this, and there needs to be an appreciation for this job and this work from a legislative end and all the way down to the CMH and the provider end to understand this is a hard job. And if you're not going to, have an appropriate wage for that job, then you're just not going to attract enough people to do it, much less people who are going to remain in that job and won't just be looking for the next thing. Whenever you set your rates low, you're going to have a transitory workforce,
Right.
and that's going to lead to high turnover and gaps in staffing. And all of those things have a direct impact on people with disabilities, kids included, who rely on those services and who those services are medically necessary for, specifically to remain in that least restrictive setting or in that family-like setting for a kid. And you also talked about taking care of the family. And a lot of times we talk about respite on that. And the same things that I say about applying to this job and why this job is difficult, it applies to the parents. And I mean, the parents are natural supports for these kids. There's a lot of difficult times for being a parent or when you're a parent of a kid with a significant mental illness. And, if our goal is to keep the kid in the family-like home and to keep the kid, whether it's their family or or at a foster home or a therapeutic foster home or wherever that family-like setting is and looks like for that child, then we need to take into account that this is hard on the family and the family needs a break. And sometimes the kid needs a break from the family. And so, respite is something that we frequently come back to. It has frequent issues with being able to obtain people to provide that service. But whenever you don't have a break, then, you break. And that's really what that service is geared towards. It's one of the few Medicaid services that aren't actually meant to, specifically benefit the Medicaid beneficiary. That's a service that's meant for, moms and dads, grandmas and grandpas and aunts and uncles and everybody, who's taking care of this population of kids, the people who are, willing and brave enough, able to step in and try to give, some of these kids a home. They need a break, and there's really, no other way to put it.
Well, I'm wondering, with the panelists, it sounds to me, and this has been my sense, as an advocate myself, that part of the issue is, I believe in, if you fund it, they will come, kind of like Field of Dreams. Seems to me that what's really needed here, particularly for specialty supports, is there needs to be some sort of a floor regarding an hourly rate that these individuals who provide these services should be paid, so that, to your point, Kyle, it would be far more attractive to flip a burger at McDonald's. I saw a sign not too long ago. I live out in Holland, where McDonald's was offering $21 an hour to people out here. How do you compete with that? So from all your perspectives, I'm addressing all four of you. Do you think it's an issue of more than a $2.35 pass through, which we're grateful for the legislature that they did that, but it sounds like there's a lot more that's needed.
I would say 100%. Yes, there is a lot more that's needed. There was a recent study that was sort of done on sort of what is the wage that would attract and keep people, right? And 18 would be a nice starting wage, but that's just the start. If you think about what the wages are of your average direct support professional, it's a little under $15 an hour average across the state, including that $235. If that's what you're making in your family, then you are eligible for Medicaid yourself. You are eligible for a bridge card if you have children. That is not a living wage. And so we absolutely need to get that wage up. But the other piece is the support and the training that we provide to direct support professionals, foster parents, respite providers, case managers, all of the people that touch our children, right? The pandemic did one horrible thing to training, although I think there was a trend starting even before the pandemic, which is, let's just do all the training on watch a video and fill out this form and ta-da, you're trained. When I started my career 37 years ago, I was a direct support professional working with people coming out of state institutions, and I had to sit in a classroom and be trained for 40 hours before I ever got to go to the group home. And then I had to have a partner with me for the first 2 weeks that I was in that group home before they trusted me to leave me alone with anyone, right? Now you read a paper, maybe watch a video, and ta-da, there you go, you're in. So I think that to really build that workforce and to build the capacity in our state to really provide quality support to children and families, because I would also add that we have to remember this kid is in the context of a family, right? There are other people that love and care about this child that are also being harmed when that child doesn't get the treatment and support that they need. And so, if there are legislators on this call, I don't know if there are any, or if any of you are friends with legislators, I think the message is that we really need to invest in this workforce that supports these young children.
Thank you, Jan.
Sorry, I got a little excited. I'm sorry.
Oh, you're
There is- I think there is an additional component as well. Is my understanding a couple of years back that Michigan adopted something like we're a no restraint state or something to that effect. I'm not really sure what the official language is around that, but what that has created is a situation where various child caring institutions across the state that have had really successful track records are closing their doors in droves, because when they are trying to support our children and youth that have these significant behaviors and frequently may be aggressive, and if they're required to restrain them in any way strictly for safety purposes, we're fine. We interviewed our advocacy group actually interviewed an organization over on the east side of the state that recently closed their doors because they had their staff trying to do their job, and just simply keep these children safe. And a whole bunch of their staff were actually placed on central registry simply for doing their best to maintain a level of safety. So I think that legislators need to very potentially take a look at that and potentially repeal that, or at the very least make some significant modification to that. And echoing to, what both Kyle and Jan have said, we've had in the past, we've had a phenomenal CLS worker that worked with our son for about a year prior to COVID. And he actually was a trained, licensed mental health care worker, but he picked up hours on the weekends because he literally could not support his family doing a job where his passion lied. And I think he worked at a bank or something, the Monday through Friday, but then on the weekends, he would spend his weekends working with my son because he felt so passionate about the job and what he wanted to do. And it's just tragic to lose someone like that who was trained and knowledgeable and willing to do the really, really tough work. But they had to walk away just because they couldn't make ends meet being in this field.
I really agree with what everyone is saying. And I think another layer of this is there's still a lot of stigma around mental health. And children that are struggling are very quickly labeled bad kids. They're labeled the problems. My family and many of the families in our advocacy group talk about how their child doesn't engage in the services that aren't being provided super well. And the result is that they cut the services or they reduce the services instead of finding new ways to engage with the child and make treatment successful. I think it's very easy to blame children for bad behavior when the system seems to be routing them to the justice system anyway. But these kids are going into fight or flight. They're overwhelmed. They need support. They need help, and they're not getting it. They're stigmatized, and then their direct care staff are marginalized and minimized. And I feel like often treated like they're not playing a significant role in the treatment of the child, even by the mental health teams, when actually the direct care staff are doing some of the heaviest lifting, and they are spending by far the most hours with the child. But I don't see the direct care staff being routinely asked for their opinions. I don't see them being routinely asked for their challenges, but I do see them routinely being told they have to do more and they have to do better and they aren't doing it right. And really, I feel like we need to take a step back and talk about and understand, like, how do we work with the challenges in a caring and compassionate way that builds up the child and the family and the staff? We don't seem to be making it there. And I think that's causing breakdowns in all of these other areas the other panelists have already spoken to.
I would like to speak to the stigma issue, Michelle, if I may, because I think one of the things I've observed is that even though it's 2022, stigma toward individuals with mental health conditions and addictions is alive and well. Despite the fact that, the pandemic has really shown us that there's a lot of issues with mental health among adults, but there's quite a bit more across the country, actually, with children and youth. But I'll give an example. I was having a conversation with someone earlier today, and what we talked about is the fact that if an individual went to a hospital for a medical condition like a stroke or a heart attack, they would be immediately taken in and treated for that stroke or heart attack in intensive care. They would not be prematurely discharged, hopefully, under most cases. And yet, the other side is with mental health, we will have individuals in emergency rooms sitting there for 30, 40 days because there's no beds available, or sent home even though they're still clearly not psychiatrically stable because there's nothing available for them. To me, that's an example of stigma in action in the form of disparity between physical and mental health treatment. That's something that really needs to be addressed, because my other issue would be that, you know, I wonder sometimes how much we value the people with the more significant disabilities, because if we really valued people, then the money, you know, the money would follow the care for these individuals, because in my mind, the values are what dictate where we spend our money from a policy issue. And that's something that is of great concern to me. So what I'd like to do now is, we have quite a few comments in the chat, and Kristen, you've been monitoring the chat box. What stands out for you that you'd like to read out loud for the panelists?
Sure. Well, there's quite a lot of people kind of stating their story, which is fantastic. One of the questions I see are families allowed to supplement the hourly wage? Can anyone clarify? And I think they're talking about if they've got in-home care workers.
Who wants to answer that?
Whoever answered that or asked that question, I think that might be a conversation that you and I can have offline on this. If you're available tomorrow, I will look up and touch base with you here tonight to try and find a time to talk to you about that. That may be a more complex answer than you might be looking for here, but I'm happy to talk to you about that, because that does have some serious considerations to think about in doing that.
Thank you.
Kyle, would you be willing to drop your email in the chat?
Sure.
Thank you. There's also a couple, questions about what is an SED, the waiver in particular. I don't know if anyone wants to speak to that. There was a link in there at the beginning. If you go to timestamp 6:25, Carly graciously put a link in there. But if anyone wants to speak on that, there may be some people on this call that are not familiar with that.
Well, I can speak on the SED waiver. It is a Medicaid waiver that children can be eligible for, even if their families are not eligible for Medicaid based on income requirements. The child is eligible for the SED waiver based on the severity of need. The child can also have private insurance. There are services that the public mental health system provides that private insurance does not offer children. And so in a way, as a way to help these children get the services that they need, the state of Michigan has this SED waiver so that the most vulnerable and the children with the most intensive needs can access the most intensive level of services. Some of the hours are what are called enhanced, meaning you're eligible for additional hours than you are if you didn't have the SED waiver. The challenge, of course, is even when you have the SED waiver, we're still having trouble accessing the services, and enhanced hours, if you can't get any of them, really don't help. But if you feel that your child might qualify for the SED waiver, or if you want to know more, I would encourage you to go to that link that was posted in the chat and then call your access center at your local CMH and start the intake process.
I would like to say also, because I know some people that have faced very significant challenges that do have private insurance. Their private insurance at this point does not really offer anything significant for mental health care. And so our advocacy group, one of the areas that we have talked about and are continuing to explore are parity laws. I don't really have a whole lot more to say about the parity laws in particular, other than it's something on our radar, and we definitely are going to continue to dig into trying to become more informed and figure out what we can do. The next step is, again, knowing about the SED waiver, requesting the assessment. And I've heard from far too many families that they go through that process and they are denied. And they're told to wait for this or wait for this. And they will frequently refer to, well, my youth didn't score high enough. What does that even mean? So when applying for the STD waiver, there is a tool that CMHs will use, and it's called a CAFAS. Stands for Child and Adolescent Scoring. Depending on the age, if your child is quite a bit younger, there's one called a PECFAS. And they do go through different subscales. There's actually 14 different subscales, and the therapist that's working with the family should go through this tool and figure out which column your child lands in for each of these subscales. And then each of these columns then have a numeric value assigned to them. And then once they're completing the CAFAS tool or PECFAS tool, they go through and they total up the scores. One of the concerns that we're having is that this process is not at all transparent. Many of the therapists are not doing this scoring or using the scoring tool in person where the parent can see. And so typically, I blank out on something at some point, but the therapist will go through and score. And then, a parent may at a later time actually find a copy of the CAFAS booklet and look through and say, how on earth did my son or daughter not score much higher when me as a parent look through these same categories and behaviors and figure out scoring? It's completely different in terms of what they're coming up with as a result. So that is, I would say, if you're a parent finding yourself in that particular realm where you're continually being denied access to an STD waiver because your child is being told that they're scoring too low, be very clear in asking for the criteria, even ask for a copy of the CAFAS booklet and ask for someone to sit down and go through with each individual score. Yes, there's potential you might get some pushback on that, but there's no reason to be hiding anything from families. There's no reason that this process can't be transparent and that there couldn't be some conversation around some of the scoring and outcomes with this. So
that's a good point that you make. When I've had to been asked to assist families with access, just getting in the door, so often it's because of the way the question was asked and then interpreted and then answered and then interpreting of the answer, right? If you don't understand the question that was asked of you, you might give an answer that isn't really what they're trying to get at, right? And so sometimes that happens. And so it really is important to be able to take your time, go over all of the questions, bring someone with you to those assessments if you can, just to make sure that you're able to give them the best information possible so that they can make that assessment as to your eligibility.
Yeah, we talk about the CAFAS a lot in our advocacy group. It's a big issue. Children are also denied a second year of the waiver, and they're told that they don't have CAFAS scores, and parents jaws hit the floor and can't understand who is making these determinations because of what they're experiencing in their homes. We talk about it a lot, and we encourage parents to download a copy of the CAFAS scoring booklet and to know to know what's being asked and to know their rights and to know what to do if you're denied, whether you're denied the SED waiver to begin with or you're denied a second year, because you have appeal rights. Even if you don't receive them, you have appeal rights. We talk about this a lot. And I mean, we're loved for it within our group, other parents that are in this same situation. We have really strong bonds because we're helping each other find our way through this, but we aren't loved outside of the group and in the system for saying, hey, FYI, we know how to link you to a copy of the CAFAS scoring booklet. But we have to do it because our children aren't getting the services they need. And if we don't stand up for them, no one else will. We also teach our families, and we talk a lot together about how to access the Medicaid provider manual and what's available in the provider manual. And across the board, we so frequently hear parents say, I brought the provider manual up at my meeting with my case manager, my wraparound coordinator, and they said, I've never read it before. I don't know what it is. Where do you find it? It shouldn't be this way. Parents shouldn't have to be more educated in advocacy than the people in the system working for them, but you have to be if you want, like if you even want to have a chance to get the services that you need, you have to be. And I will also add that I think a lot of the people in the system are very good people and very well intending, but the training isn't there and the consistency isn't there. And it's negatively impacting not just our children today, but it's impacting the trajectory of their lives.
Thanks for that, Michelle. I want to switch gears just for a minute because the question keeps coming up about accountability and oversight in the current system. Does anybody here want to talk about, whether, what your thoughts are about accountability and oversight with regard to the current system? And do you feel like there is accountability and oversight when a community mental health service provider or a prepaid inpatient health plan isn't maybe doing what it should be doing or responding in a way that it should? And whoever wants to start, please do.
The whole process when you're dealing with behaviors is already so overwhelming. Then to wrap your mind around the thought of having to go through a whole bunch of paperwork. But in all reality, when you are able to identify that you did not receive, your youth did not receive the services that they are eligible to get, there are specific processes that you go through. You can file appeals to some decisions, like if you request something, a specific service. For example, for my family, we were receiving 6 hours of CLS service, community living services, prior to him going to detention. And so I was looking at the Medicaid provider manual and discovered I could request much more than that. So I went back to my wraparound team and requested 35 hours a week of community living services. And they did increase by another 6 hours. So 12 hours total. However, I was asking for 35, and there was a very specific reason. Again, my son's behaviors in the home are very unsafe, but he seems to do well with having that CLS as a behavior model, kind of walking alongside him. And so we received a denial. So when you receive a denial for services, you are supposed to receive paper documentation, an adverse benefits determination. When you receive that paper, that allows you then to go ahead and take the next step and file an appeal, which sounded really overwhelming to me. But truthfully, when I've actually gotten into the thick of it, it's frequently been a phone call. Like I could make a phone call to my CMH and file my appeal. They'll take it over the phone. So it's not like you have to sit there with pen and paper and write out your whole story one more time and why you don't agree. So that is actually one thing I will say on their behalf, that they are willing to take your appeal over the phone, and they do mail you a copy so that you can verify that they copied it down correctly. There are also ways to, if you feel like rights are violated, you can file a grievance. The problem is, what we have found so far, at least in my situation, is that filing the appeals and the grievances, even though it is that formal process and you do need to do it, you have to do it to establish your trail of efforts and what you're trying to accomplish. And but it's still not getting us anywhere. These grievances and appeals are falling on deaf ears. So that is, again, one of our advocacy points that we're trying to hit really hard, is that someone needs to be made accountable and provide oversight to these things. So I'm sure someone else has a lot more they can share, but
Yeah, Laura, I think a big part of the problem as someone who has filed a lot of these is that they are reviewed within the same system that you're filing them against. So as a parent, we're kind of put in a really hard spot of there's a booklet that defines what your rights are. And if you feel like one has been violated, you can file a rights violation, but you're often filing it directly against your provider or your staff, and they can choose not to work with you anymore. And like, then what? Can't if you can't get the staff you need anyway, and then you lose your staff because you've complained about your rights being violated, you're not really any better off. But a lot of times I personally feel that the investigation system is set up with an eye to protect the system. It's almost like certain things can get picked out, and I'm not saying it's intentional, but it's almost designed to create the highest amount of proof possible for things to be substantiated. And like, really, as a parent, I'm not in this to get rights violations substantiated. I'm in this to get problems solved. Like, I just want problems solved so my family can have the support that they need and we can get the treatment that we need. But I feel like it turns into a paper trail arm wrestling match. And it just like goes back and forth, and no one actually really wants to step back and say, how do we solve this? So you have to file another grievance and another rights violation. And I had a very kind rights officer say to me, oh, thank you for telling me all of this, but could you please put it in writing too? Because I really like reading what you write. I don't want to this isn't the novel I want to write. I want to help my child get the services that are needed so that we can move forward. I don't know if we can do that so long as the accountability lies within the same system, the same local level we're having problems with.
Thank you, Michelle. We actually have a couple of questions that Kristen wanted to share from the chat. Go ahead, Kristen.
Sure. David asked, will I lose Medicaid and CMH services if I place my son on my VA healthcare? So David is a 100% disabled vet, and that's where he gets his insurance from, is the VA. And if I didn't say that question correctly, David, you're welcome to unmute yourself and chime in.
I don't know the answer to that question. Kyle, do you, or Jan, do you?
Yeah, I'm sorry, David. I don't know the answer to whether or not you can be eligible to be enrolled in both of those. You know, you can have Blue Cross Blue Shield and private insurance and receive Medicaid benefits. There are requirements that you exhaust third-party payors before you can access Medicaid services. But whether or not you can enroll in both of those programs, I'm sorry, I just don't know. And it would be certainly something worth inquiring with the CMH that you're working on whether or not you can do that. I think, you know, generally speaking, the more places you can access benefits, the better. And if the VA is a spot that can do that, it can do that in coordination with what you receive in Medicaid, that it's certainly something worth looking into. And I'm sorry, I can't answer that question off the top of my head.
Oh, CMH asked you the question, so
Okay.
you're not gonna be able to get your answer from them. So, you know, one thing is, if you've got the SED waiver, right, that is a specific waiver that waives some of the other rules like income and assets, right? So with private insurance, with families who have a job and they have private insurance, or they have income of some sort and they have private insurance that makes them ineligible for Medicaid, typically, they can still get that SED waiver because those income and resource requirements are waived. And so the question might really be to the VA to ask them two things. I think number one, do they offer an array of services, or could they fund some of the stuff that you need for your child, right? Through that insurance. And number two, if you put him on that insurance, would that preclude him from other federally funded insurance programs, AKA Medicaid or Medicare, right? So that would be the question you could ask. Two questions, right? One, do they have the ability to pay for some of these services you need? Or two, does being on that government insurance program preclude him from being on Medicaid?
The more I think about it, since Medicaid is the payer of last resort, the VA would probably not provide those services that CMH would provide. So I almost feel like it would default to the Medicaid funded services anyway.
Right.
That
I
would
think
make
you're right
sense.
about that. It's just a matter of eligibility, right? If there's
Yes.
too much resource. So
Exactly.
Okay, and then there's other question, which Kyle, I sent to you, but if you could give the answer to the group. What is MDHHS's role versus CMH's role? In other words, who's in charge?
See, there's people from the department on the call here today, so let me try to answer this in a way that I don't get an angry phone call from an attorney general tomorrow. So let me start here before I answer that question, because we talk and you use the term public mental health system a lot. And I want to explain what that is before I answer this question. And that public mental health system is at its first part funded by the federal government, primarily through the Medicaid program, where the federal government gives the state a lot of money to run the Medicaid program. In exchange for that money, the state agrees to comply with the various laws and regulations that pertain to the Medicaid program. At its core, the Medicaid program's purpose is to provide medically necessary covered services to people who are eligible and participate in the program. So very generally speaking, the state is agreeing to provide those services in exchange for the money that it receives from the federal government. And the way, in particular, for mental health services and specialty behavioral health services, the way that this particular system operates is carved out and separate from what would traditionally be categorized as straight Medicaid or physical health Medicaid, however you'd want to call that. That funding is structured in a managed care network, and that looks different in every single state. And in this particular state, we have 10 regional prepaid inpatient health plans. And those health plans contract with the state to undertake those responsibilities, or a large portion of those responsibilities that the state just undertook from the federal government. And in exchange for undertaking those responsibilities, they receive capitated rate payments. So they receive money in the form of per person payments that vary depending on which program the individuals in their particular region participate in, and undertake various responsibilities to obtain that money. And the prepaid inpatient health plans then in turn contract with local community mental health. So I forget where we're at, we're over 50. Specialty mental health or community mental health specialty programs that their purpose is to be on the ground and to take that money or to submit claims and be reimbursed for those claims out of that pool of money from the prepaid inpatient health plan. And then they contract with what are primarily private healthcare entities, agency providers, the providers who are going to be providing your CLS and your respite and your therapy and all the benefits under the program, and paying them out of the reimbursements that they're receiving from the prepaid inpatient health plan. And ultimately that should result in somebody having a service provided. So that's a lot of layers to get from the federal government down to the actual service provision. And that's a lot of entities that are, entering into contracts or complying with federal law revolving around guarantees for people to get medically necessary services. So whenever you ask the question, who's responsible, then the answer is that really three entities are responsible: MDHHS, the prepaid inpatient health plan in your region, and the community mental health. They all have a responsibility either through law or through contract to make sure that you're getting the medically necessary services that you're entitled to as a participant in the Medicaid program. And what that creates, and what may well be the inherent vice in the managed care system as a whole, whether it's in Michigan or any other state, is that you have three entities that are responsible for the same thing. And so then you get into accountability and responsibility. MDHHS is the one who gets the money from federal government. MDHHS is the one who makes the guarantees under the program. MDHHS is responsible for making sure that it works, not only that it's funded in particular, or for children, not only that it's funded, but that the services are actually provided. And so, the answer is that everybody's responsible, and in my view, it's MHHS that really is in the position as the single state Medicaid agency, make sure the system's accountable, make sure it works, and make sure that people are getting the services that they need and that they're entitled to under the program.
Thank you, Kyle, for that. And thank you, everyone. This was a really interesting discussion today. And I really want to thank Laura and Michelle and Kyle and Jan for their perspective. And I want to thank all the participants, but particularly those of you that were putting comments and questions in the chat box. One of the things we really endeavored to do with this roundtable is we really wanted to talk about solutions. And I've been around this system too for a very long time, over 30 years in some way, shape, or form. Some of the observations that I've had, if I can share, as an advocate, as a, secondary consumer, as a former CMH director, as a case manager. One is the system, in my opinion, really is underfunded in certain ways, and that dollars for programs such as those that keep individuals out of institutions definitely need to be earmarked and directed towards certain services. And there definitely needs to be a floor with no ceiling for rates of, pay for individuals. That's number one. Number two, when it comes to accountability and oversight, and I've said this many times, I think one of the problems is the way that, and I know there's some PHP directors on here, but the way that the board of directors for the multi-county, well, actually the PHPs in general, the way the board of directors are configured, particularly those multi-county PHPs under the regional entity statute, where you have the CMHs who are actually members of the PHP, who are supposed to be held accountable by the PHP and have their own CMH board members on those board of directors of those PHPs, is very problematic and fraught with a lot of conflict of interest. And that is something that needs to be addressed, and it hasn't been addressed. When you consider that the whole purpose for a PHP is two things. One is to cut the check to the CMHs. Number two, to make sure that the CMHs are held to the rules, lots and lots of rules and regulations that are inherent in that over 700-page master contract between the PHPs and the state. So that's an area that absolutely needs to be looked at as well. The other piece is that families, need to be given help navigating the system, and having the ability to provide navigators to families who have children with serious emotional disturbance in the system would be very beneficial. A policy issue is the fact that because of changes in restraint and seclusion policy at the state, and I'm not saying that children should be unnecessarily restrained and secluded, but what happened was back in the day, back in the 90s, early 2000s, we had some really, really good child caring institutions that received funding, Medicaid funding from CMHs for kids who didn't quite qualify for state hospital, but were stepping down from the state hospital and needed to be in specialized residential for a while. We don't have that anymore because CMHs can't use Medicaid in those institutions. And the reductions in state general fund in 2014 have really hurt the public mental health system in a very significant way. So, those are just some areas where we need to take a long look at public policy. In the governor's budget, in the budget that was adopted by the legislature, I should start there, we saw $625 million in investments in behavioral health infrastructure, with, proposing a new campus for Walter Reuther, which is a state psychiatric hospital, new Hawthorne Center, improvements in Hawthorne so they can add more beds. That's great, and we definitely need that. We need more acute care beds for children and adolescents. By the same token, we also need to invest in keeping people out of institutions. And going back to the earlier conversation about what does it take to solve the direct care worker crisis, I will say this again: if you fund it appropriately, they will come.
I just wanted to thank everyone. I know there are you know, a lot of people from many different walks of life that chose to spend their time investing in listening to this conversation. So many families that are in current crisis that are choosing to use their time to sit here and listen and even contribute some comments and questions. Legislators and other, you know, people in positions that can potentially affect positive change in the state of Michigan. And I just so appreciate anyone that's willing to devote this time to listening to this discussion. I can't say it enough. I mean, we're going to continue to advocate for families. And I hope that everyone here is willing to move forward and continue to have these conversations in the best, with the best of intentions.
Yeah.
I agree, Laura. Thank you so much for the invitation to participate and to everyone who came. It's not just about my child or Laura's child. This is about making the system better for all of our children and for all of the families that need help and support.
We're very interested in continuing the conversation because my passion for this is this. You know, when my son was, again, I say 30 years ago, a child with SED, he got services really young and now 36. He has not been in the system in 30 years and is a fully functioning human being. And I attribute that to the fact that he got help really young. So he's not a lifer in the public mental health system. So, you know, my goal as the head of MHAM is that no child or youth or adolescent ends up being on disability and in a lifer in public mental health when they could be a fully functioning human being with a full life. Not that people in CMH don't have full lives, but let's be honest, a lot of them are on disability and struggle greatly. And so, you know, the goal here is to provide as much opportunity for healing and engage in prevention as much as possible. So with all that said, thank you again for joining us. I put my email in the chat. Feel free to email me. I want to encourage you to check out the group that Rachel, who's not on the panel, but Rachel Murray, Laura Marshall, and Michelle started back in January, and they will give you the detail from there. So thanks, everyone. Have a wonderful evening. And I guess I want to just say this, as long as we all work together, I think there's a lot of hope. I want to make sure I say something positive to a subject that can be pretty depressing at times. Take good care of yourselves and have a great evening.